So CPR, cardio, that's your heart. Pulmonary, that's doctor speak for lungs. And resuscitation is the act of reviving a third party by beating their heart and breathing for them. So that's why it's CPR. Now, in any given emergency situation, the first thing you want to do is your primary survey. So your primary survey tells you what to do and in what order to do it so that you don't forget and miss anything out. So that's where the board comes in. Now, I'm hoping you can all see that okay from there. So the most important word that any first aid trainer can ever teach you is this one. And it is...
Can't see the board, Kerry.
You can't see the board?
Nope.
It's right in the middle of my screen.
Just they're screened out by the little people down the side. Now I can see it.
Are they? So if I'm writing on the board, then it needs to be in the middle for you, yeah?
I can see that now, yeah.
Now, okay then.
Yeah.
So the first thing we're going to do, so you walk into a room and you see somebody who is on the floor. What do you do? Well, the first thing you usually do is panic, scream, swear, and forget everything anybody's ever told you. That's completely normal. Once you've done that, I want you to remember sitting there, looking at your screen now and seeing drab on the board, because that's going to tell you exactly what to do and in the right order. So the first thing you have there is D. Now your D stands for danger. Now the dangers that you're thinking of are not just dangers to your patient, but dangers to yourself as well. So things like, is the reason that they are in difficulty because they've been electrocuted? If that has happened and you go to help your patient and you haven't switched off the power, then you're going to be electrocuted as well. You've made this situation 100% worse than it was before you got involved. Other dangers would be things like, is there glass on the floor? Are you going to cut yourself if you kneel down to try and help them? Perhaps there's water. Has your patient slipped? Are you then going to slip and fall over as well? So before you go anywhere near your patient, you must be absolutely sure that it's perfectly safe for you to do that. Once you have done that, you're going to move on to R, which stands for response. Now, a response is a two-way street. It's a conversation. So I ask you to do something and you do something back to let me know that you've understood what I've asked of you. So the easiest thing to do is to just talk to your patient, say, hello, hello, can you hear me? Can you open your eyes? Now, the reason that we say, can you open your eyes, rather than, oh, squeeze my hand or something like that, is because if your patient is significantly impaired and perhaps paralyzed from the neck down, if you ask them to squeeze your hand, then they might not be able to do that, when actual fact they can hear you perfectly well. So simply by giving them an easy instruction like open your eyes, that's simple for them, even if they are paralyzed, they can still do that. Now, if they are so badly off that they can't even open their eyes, you may be able to get what's called a pain response. Now, the easiest way to get a pain response from your patient is simply by taking hold of the earlobe with your fingernails and nipping it on the lobe there. If you do that, it is painful, but it doesn't actually hurt your patient per se. So you're liable to get a response off that where they may wince. Another thing that you can do is take your knuckle of your finger there and on your patient's clavicle, on the collarbone, put that on and just sort of push with that. That's quite a painful sensation, even though you're not actually harming your patient. So by doing that, you are liable to get a response. Again, if you don't get anything from there either, then you're going to move on to checking pupil dilation. So your pupils are the black bits in the middle of your eyes. When your eyes are closed, your eyelids are covering over the pupils, preventing any light from getting into the eye. So the pupils will be really big and dilated because they don't have to do anything. When you open the eyelids up, all the light will try and flood in, and in doing so, the pupils will respond by shrinking down and constricting to keep that light out. So what you're going to do is lay your fingers gently on your patient's eyelids and open them up and watch to see what the pupils do. You should see both both pupils constrict down at the same time to keep the light out. If one constricts more than the other, or perhaps one doesn't move at all, that's usually down to the fact that there's been a head injury. This half of the brain controls this eye, and this half that eye. So conversely, the side that looks like it's responding properly is probably the side of the head where if there is an injury that you're liable to find it at that place. So we made it safe, then we checked for a response. The next thing you're going to do is A, which is airway. We need to make sure that the airway is open so that the patient can definitely breathe. So the airway is everything from the mouth down the windpipe and into the lungs. If that airway is blocked, your patient is definitely in trouble. Your B stands for breathing. Again, if your patient is not breathing, you know that they're in big trouble. So these 4 things are the most important. Once you've made all of your checks, that is the point where you ring your ambulance. So in the UK, it's 999. Tracy, I'm not sure what the standard procedure is in South Africa, but whatever your emergency number is. The European International emergency number is 112. So if you are on your holidays in Spain or in Greece or France or anywhere in Europe, 112 is your number to ring. And because we are still, I think, part of Europe, 112 still works here in the UK as well. So either 999 or 112 are both perfect numbers for you to ring. The reason that we do all of our checks before we ring for an ambulance is you might find if you came in panicked and rang straight away, the first thing that they're going to say to you is his airway open? Is your patient breathing? Well, if you haven't made these checks, you're just going to have to say, oh, I don't know, hang on a minute while I go and have a look. And this is all time that you're wasting. So it's better to access all of the information first before you ring the emergency services so that you're armed with all the facts and you don't waste any time. Once you've ascertained whether he is or isn't breathing, that's the point at which you would start your CPR if you were going to do that. And I will do a demonstration in a minute to show how you do your CPR. But essentially, your CPR consists of 30 compressions over the heart itself, and then 2 breaths into the mouth to inflate your patient's lungs. 30 to 2, 30 to 2, and you just keep swapping 30 to 2, 30 to 2. The only time that you would stop alternating between them is either if the emergency services arrived, in which case they would tell you when to stop. Please do not just see them walk in the door and stop what you're doing and get up. You've got a really good rhythm going. It's going to take them a couple of minutes to get their gear all together anyway. So it's better for you to carry on until they tell you to stop. Another reason for stopping might be that the patient is showing signs of life and you've been successful. The signs of life that we would be looking for then would be actually seeing the chest inflate and rise. There is something called agonal breathing, which is a subconscious reaction that you often see, particularly after something like a cardiac arrest. If your patient does agonal breathing, this subconscious spasm is sort of like a that looks like the patient is breathing, and it fools quite a lot of people, but those actions are not breathing at all. So unless you see the chest wall actually rise, discount those movements entirely because it's just spasms in the body. The third reason for stopping would be if your patient vomits, and if your patient does vomit, you would need to clear away the airway, turn the patient back over and start again, and I will demonstrate that for you as well. But otherwise, we just carry on with 30 compressions to 2 breaths, 30 to 2, for as long as you can. You know, if you're tired and you can't continue, then so be it. Is everybody with me so far before I start the demonstrations?
Yeah,
Yep.
really good.
Yeah,
Can you just spell agonal?
Yeah.
Agonal, yeah, I'll write it on the board for you. A-G-O-N-A-L. Agonal.
Thank you.
Okay, so agonal breathing, you often see it after a drowning incident as well. There have been times where lifeguards and things, I know one in particular, there were a couple of lifeguards scooped a 7-year-old girl out of a swimming pool in Newcastle, got her out onto the pool side, commenced CPR. she started doing agonal breathing and they didn't know what it was. And when they saw it, they just thought, brilliant, we've done it. And they popped her into the recovery position. Sadly, it was agonal breathing and not real breathing, and that little girl didn't make it. So it's really important that you are aware of what that is. Do not let anything fool you. The only thing that counts as breathing is physically seeing that chest wall rise. If there's no chest wall, that patient is not breathing no matter what they're doing. There's actually a really good video that you can see on YouTube. It follows the Bondi Beach lifeguards, and they I think they're filming for a Discovery Channel teleprogram that they were doing. And while they were filming, a real life emergency unfolded on the beach, and a chap had been on a surfboard and he washed up and he'd been drowning. So when they got him out, he was lifeless and they had to do CPR and everything on him. They actually get him back at the end, so it's definitely worth watching, but you see agonal breathing quite clearly in there. So it's a good video and it's worth pulling out. It's Bondi Beach Rescue, and if nothing else, young men running around in little tight shorts with a nice body, that'll do. I'm sure that's not very PC, but I can get away with that with you lot, that's okay. So quick demonstration then for you. I won't keep you too much longer, so I'll move the board out of the way.
Can I just say, Kerry, as well, just while you're changing over, if anybody wants to get rid of the little people on the right, there's an arrow at the bottom of them which is pointing to the right. You can click that and they'll vanish.
Oh, cool. Yeah, got you.
Okay.
So I'll introduce you to my faithful assistant, not nearly as handsome as Axel Chai, Rain or Dice, but here you go. For human stuff, she'll have to do. So what you see as you look at her, I don't encourage you to hold people by the throat, but it's the only way I can show you from here. You'll notice you can draw a line between nipple to nipple and nostril to tummy button. Where that line crosses, that is where I want you to do your CPR, right in the middle. Now, if your patient is a lady with droopy boobies, people think, oh, well, I'm going to be down to a stomach and that's not the right place. Actually, that's not what happens with droopy boobies. They tend to fall sideways between your armpits. So they still be in line anyway. So if you need to use droopy boobies, you can go with that and that's absolutely fine. So I'm just going to put her on the floor and adjust the camera. So hopefully you'll be able to see what I'm doing. Okay, so we checked for danger and we made it safe. The next thing, we're trying to get a response. So when you're trying to get a response off your patient, I'm going to use the backs of my hands to pat on the chest wall there. So with the backs of my hands, hello, hello, can you hear me? Can you open your eyes for me, please? Hello? Now, the reason that we use the backs of your hands to do this, it's particularly important, especially with fellas. If you use the fronts and you do it like this, it could be misconstrued that you are doing something that you shouldn't be doing with boobs. We don't want to get into trouble. If you use the backs of your hands, it's quite clear that nothing you were doing was inappropriate. So that's the reason we do that. When you speak to your patient, please don't be lovely. Hello, hello. That's absolutely no use whatsoever. You need to get a loud, commanding voice on so that you can cut through any of the haze or fuzz. If somebody is in and out of consciousness and you're just being all lovely, you're unlikely to get a response from them. So say it like you mean it and ask, hello, can you hear me? Can you open your eyes? If you don't get a response from that, as I said, we can either pinch the earlobe so that we can get a pain response that way, or use your knuckle on your finger, actually on the clavicle there, and elicit a pain response from that perspective. So that's D for danger, made it safe. R, response, didn't get a response. So next I am going to open up the eyelids and see if there's anything there, any kind of response or reaction. The eyelids will, as I said, they're covering up the eyes, so they're stopping the light getting in, so we can check that. Next, we're going to open up the airway. Now, to do that, you need to be very careful because there's always the possibility that there may be a head, neck, or a spinal injury. We don't want to ride the head around. So you're going to use 2 fingers on each hand, 2 fingers on the forehead, and 2 fingers under the chin, and then you can extend the neck all the way back, and that will give you this nice straight airway. It will pull the tongue off the back of the throat. So if you lie in this position, the tongue will naturally loll backwards, and that will cover over the airway. In a lot of cases, simply by extending the neck and pulling the tongue off the throat, that might be all that your patient needs. And they're able to take a breath because the airway is no longer blocked. So once you have the head and neck extended, keep the patient in this position while you check to see if they're breathing. So head all the way down to the nose. You'll hear if they're breathing. You'll feel it on your cheek. And because you're in this position, you will be able to see along the chest wall as well to detect whether or not it's going up and down and whether your patient is breathing. So you need to wait about 10 seconds to make your mind up whether you can or cannot detect any breathing. If the patient is breathing, pop them into the recovery position. If the patient isn't breathing, that's the point where you ring your 999 and you speak to your ambulance crew. Now, if you have somebody with you who can make that call for you, they can do that while you get straight on with your CPR. If there's nobody with you and it's just you alone, as at the moment, because we're in isolation, there's a very good chance that that would be the case, then what you need to do is dial 999, pop it on speaker and put it next to you. They will talk you through what you need to do, and it's like having an expert holding your hand while you're actually doing it. So stick it on speaker and let them talk you through what you need to do. So you're going to start with your 30 compressions. Now, the reason that we start with that is because your blood has oxygen in it. So you've already got lots of residual oxygen in your bloodstream. So as soon as you start doing your compressions, you're being effective in getting that oxygen around the patient's body. Now, when you do your compressions, we can either put one hand down, put the other hand on the top, interlock your fingers and pull them up. We only want the heel of your hand actually touching your patient. So as we said, we think of a line nipple to nipple and a line from the nose to the tummy, and the heel of your hand is going to go right in the middle. So you need your knees shoulder width apart. There is absolutely no point in having them close together like this because you'll be wobbly. And fellas, there is no point in doing it like this. It's not a pantomime. The number of fellas I see, and I have no idea, it's all a bit in there, but you know, hey ho. So knees shoulder width apart so you're nice and stable. Heel of your hand right in the middle here. Other hand on top, interlock your fingers and pull them up so that they are not touching your patient. Then from that position, keep your arms locked out straight and lean forward. Lean, 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 lean until you hear that click. Obviously, a real person shouldn't click. If your real person is clicking, you've broken a rib or something, but we'll come back to that. So what we're doing is leaning so your body weight is putting the pressure on rather than your muscles. If you're using your muscles to do this, you're going to be absolutely exhausted very quickly. If you use your body weight and just lean forward, you can just bounce, and that is much, much easier for you to do for any length of time. What I would say is you may find it uncomfortable in that position, particularly if you have arthritis in your hands or little hands. It makes it difficult, and I personally have small hands. So what you can do, rather than doing it that way, is putting your hand down but turning it, putting the other one on the top so it's like a butterfly, sort of grabbing around your own wrist and doing it in that position, because from there it's a lot less painful on the wrists. We still keep the elbows locked out, still lean forward and still bounce, but that's a lot more comfortable to do it in that position. Now we're going to do 30 compressions, as I said before, that's on the board. Speed wise, I'm sure you might have seen the advert with Vinnie Jones on. He does it to Staying Alive by the Bee Gees. That's just the speed that you want. I prefer to do it to Another One Bites the Dust by Queen, but Mike says I'm sick and I really shouldn't do that. He said it doesn't look very good if I'm like, another one bites the dust. But hey, no, whatever works for you. But that's the speed that you are looking for, that kind of speed. You don't have to sing out loud, and it's probably best not to look like you're enjoying it too much, because that looks a bit sick as well. But if you need to sing out loud, that's going to help you keep a rhythm, knock yourself out, that's fine. But it's 30 compressions that you do. Now, if you get going and say you're halfway through, you're really into it, and then for whatever reason, you lose count and you're not sure how many you've done, please start again at 1. So even if you'd already done 25, if you lose count, start again at 1. It's absolutely fine for you to do far too many compressions. If you end up doing 55 by mistake, no problem with that whatsoever. If you do less than 30, that's not effective. The reason for that is the first 10 or 15 that you do does the job of starting to get the blood to move, and the next 15 does the job of actually delivering the oxygenated blood around where you need it. If you're only doing a few and then stopping, you're just getting the blood to move and the blood pressure to start to build, and then you're letting it fall again. So that's not going to work for you. So always, I would say, if with first aid, whatever you're told, always do more rather than less. So if you're told 2 inches, do 2.5 inches. If you're told 30, do 33, whatever. But always at least 30 compressions is what we're aiming for. How far to push down? If we've got an adult, we're looking at about 5 or 6 centimetres, which in old money is about 2 inches, something like that. That's what you're actually pressing down. Press down, keep your rhythm, and do your 30 compressions. Once you've done your 30, you're going to put 2 breaths in the patient. Now, to get the breaths in, you need to make sure that you pinch the nose to get a really good seal. If you don't pinch the nose enough, when you breathe in, the air escapes out the nostrils, and that's ineffective. The other thing that you need to make sure you do is get a really wide mouth, channel your inner Mick Jagger, and get all the way around your patient's mouth. Because again, if you're going to go for a little mouth, air is going to escape out the side of the mouth there, and that's not going to work for you. So big wide mouth on you, good seal on the nose, and make sure that the head is extended all the way back so the tongue is out of the way so that you can get the air in. So we tilt it back with 2 fingers all the way back. Get hold of the nose. Now, if you're struggling to hold the head back and the nose and lean over because you're a bit wobbly, pop your elbow on the floor and that will stabilize you so you're nice and stable. Then when you get hold of the nose, you can put the breaths in. Come all the way out of the way. Again, in between each one. Now, I don't know if you'll be able to pick it up on the camera or not. I'll get a bit closer so you can see her. You can see the lipstick around the outside. That shows you how wide your mouth needs to be to get all the way around the outside so that no air escapes. Now, in between each breath that I gave, I let go of the nose, came all the way out of the way, but kept the head extended so that the airway remains open. Now, the reason that you come all the way out of the way in between each of your 2 breaths is because if the reason your patient is unconscious is perhaps there's been a house fire, something like that, and they've inhaled smoke and toxic fumes and chemicals and that kind of thing. If you stay hovering over your patient like this, as they exhale, you're going to breathe in whatever it was that knocked them out in the first place. The other reason for coming away in between is they may well vomit. And if you stay here as they vomit, then you're going to get a face full of whatever that is, and you really don't want that at all. So make sure you get used to coming away. So 30 compressions, 2 breaths. 30 compressions, 2 breaths, and you just keep going. Now, if the patient is unlucky enough to vomit, what you need to do is gently roll them to one side away from you, pop your finger in the mouth and unblock the airway. Then roll the patient back over and recommence your 30 to 2, 30 to 2. Now, if at that point you think to yourself, I'm not snogging that now because he's all vomit and carrots and blah, if that's the way that you feel, that's absolutely acceptable. Nobody expects you to put yourself in harm's way. In fact, the first thing on the board that we wrote was D, danger. And bodily fluids can be quite dangerous for people, especially if it's somebody you don't know the history of, and particularly at this time as well with coronavirus and what have you. So if you're not comfortable doing the breaths, that's completely fine. We can do something called hands-only CPR, and that is exactly what it says on the tin. We're just doing CPR with hands only. So position either, as we said, interlock fingers, or as the butterfly, lean forward and do your compressions. Now, you need to be doing usually 30 to 2. But if we're not doing the 2 because you've decided you're not doing the breathing anymore, there's no reason for you to stop your compressions. And that might be that you do as many as 400 without taking a rest in between. So literally just keep going. My arms are nice and still. And you can see, actually, my hair is hardly moving. That's telling you how little effort it's actually taking me to do that. Now let's look at me not leaning forward and using the muscles to do it instead. Can you see how much more effort I'm having to do in order to elicit those compressions? So if you're a little person like I am, and it potentially could be 20 minutes, half an hour before the ambulance gets to you. I nearly said before the vet gets to you. Do a lot more dog than human these days. Because it might be a while before the ambulance gets to you, you want to do everything you can to avoid being exhausted. Now, if there is somebody with you who can help you with your CPR, it's important to remember that you do everything as I've demonstrated, and then as you go to put your breathing in, the person slides alongside you and then they take over. We want the person helping to do everything. So the breathing and the compressions. After a couple of minutes of them doing it, you slot back in and you do 2 minutes of all of them. The only people who share it in as much as I do the breathing and you do the compressions are people that regularly work together in a buddy system. So people like lifeguards that train regularly and they know each other's rhythm and they've got a routine with it. Because that's not us, it's much more effective if we do everything ourselves in our rhythm, and then party number 2 comes in and do everything theirself. So that's the way that we'd like to do it. Now, the only other thing that we need to mention is difference that we would make if it was a child or a baby that we were doing. So as we've done with an adult, we did 2 hands, either this way or that way, to do your compressions. If it's a baby, you're going to use 2 fingers. Still in this position, in the middle, but your 2 fingers and push down 1/3 of the depth of the chest. So rather than thinking 2 inches or whatever, it's a baby. So just push down with 2 fingers 1/3 of the depth of the chest. If it's a child up to about the age of 5, we're going to do it just as we did, but you're going to use 1 hand and tuck the other hand out of the way. And 1 hand should be enough pressure for a very small child to do it that way. The only other thing to mention differences wise is with an adult, and this is the way that I'd like you to remember it, is we went straight in, 30 compressions to 2, 30 to 2, 30 to 2. If your patient is a child or a baby, then what we can do is put 5 breaths in before we start to do anything. The reason we put the 5 breaths in is they are a smaller person, therefore have a smaller blood volume. And by default, if you've got a less blood volume, you've got less oxygen available in your residual bloodstream. So before you do anything with a child or a baby, you're going to put 5 breaths in to top them up with oxygen. And once you've done that, forget all about the 5 and just stick to 30 to 2, 30 to 2, 30 to 2. So that 30 to 2 are your golden numbers, and that's the same whether that's your mum, your sister, your cat, your dog, whatever. 30 to 2 is absolutely everybody. The only time that the 5 comes in is if you have got something like a child or a baby, or it's your cat or your dog. 5 breaths first for them, and then we go straight to 30 to 2, and that's the way that we do it.